No one ever randomly wakes up one morning and decides that what they really want to have is spine surgery. Spine surgery is intimidating, and often patients have dealt with chronic pain over a long period of time or severe pain that's developed over a shorter period of time before they would even be willing to consider it. Once that decision is made, however, and the patient's willing to undergo the surgery regardless of how big or small the surgery seems, the hope is that this will take care of the pain. They will have made the big decision to undergo the surgery and do what has to be done to get better in hopes of returning to what life might have been like before the pain started. I see patients every week that have been through the process. They made the decision to have the surgery, they went through the recovery, and things either went really well, the pain went away, and now there's a new issue, or unfortunately, in some cases, things didn't turn out the way that they'd expected. They're still dealing with pain, whether it be in their back, neck, arms, or legs. The spine is so complex and unique. There's often a misconception that having a spine surgery should be similar to having a hip surgery. Most people know someone who's had a hip replacement, or in many cases, they know someone who's had both hips replaced. You would never assume that the fact that the friend went in to get the second hip replacement, that this was an indication that the first hip replacement was a failure. It's just that everyone understands you have two very separate hips. However, when it comes to spine surgery, similarly, many people will know someone that's had a fusion, and often people will know someone who's had more than one fusion, and it's still often assumed that this was a failure of the first fusion. While that can sometimes be the case, it's not always due to a failure of the first surgery. There are 7 cervical vertebrae or bones in the neck, there's 12 thoracic vertebrae with ribs, and there's 5 lumbar vertebrae in the low back, and these sit above the sacrum, which is attached to the pelvis. When patients have problems as a result of arthritic changes or trauma that warrant a fusion surgery, this can offer significant relief of pain. But this still leaves the possibility of other arthritic changes that can occur. Sometimes this happens at the levels above or below a fusion, due to the increased stress at those levels. This is known as adjacent segment degeneration. In other cases, it could be that the fusion doesn't fully heal, and this can result in persistent back pain, broken hardware, or new nerve compression. These are some of the examples of when a redo or revision surgery might be warranted, and this can occur anywhere in the spine, but most often it occurs in the neck or the low back. This can obviously be frustrating for anyone who now has to consider not only going through another surgery, but what can at times be an even larger surgery. This is why patient education is so important. Taking the time to figure out exactly what is causing the pain and what the most appropriate solution is. At times, this could be something simple, like a minimally invasive surgery to address a compressed nerve. But other times it means doing an even larger surgery, maybe to add more curvature to better align the spine, but to do it in such a way that we can be confident that the surgery will be successful.